We'll be talking about very brief examples of trauma. We won't go too much into detail, but sometimes hearing about examples of practice and trauma when you're in a training session or a webinar is very different from listening to it in your day-to-day practice. So if you do feel impacted by this session, make sure you have someone you trust that you can talk to, whether it's a trusted colleague, a supervisor, or an EAP if you're in an organization. Next slide, please. So today we'll talk about specific aspects of trauma-informed practice. Trauma-informed practice is a massive subject. We won't be able to cover everything in an hour. We will be talking about creating safety and a truly collaborative approach to decision-making. We'll talk also about having a shared language across disciplines and how that can support good outcomes in terms of trauma-informed practice, and also about reflective practice and how important and central it is to trauma-informed practice. We'll also talk about trauma-informed risk management and how to support people feeling safe in a trauma-informed manner. And we'll talk about supporting worker safety and well-being as well, because that's so central to being trauma-informed. Next slide, please. So as I mentioned, throughout this session, we'll be mentioning a whole range of resources that can support you in your trauma-informed practice and that we'll be pointing to from time to time during the webinar. They're available on the link just here at Phoenix, Australia. Akin can also put the link into the chat as well. And it's backed up by a whole range of longer training if you're interested in having further training. Next slide, please. Before we start talking about trauma-informed practice, I really want to make sure we have a common definition of trauma that cuts across all the very different models of trauma-informed practice we hear about. It's really important to think about trauma not just from an individual perspective, but from a systemic perspective. Trauma often does not only impact an individual, but their families. The individual themselves may be part of a community that's experienced trauma, sometimes across generations. And it's really important to think about trauma in terms of what maintains and creates trauma in the first place and how that may impact on your practice. So often with trauma, what we see is that it comes with a range of risk factors around discrimination, like racism, for example, poverty, social exclusion. And these things not only can lead to experiencing more trauma. So a classic example is family violence, and that norms around gender and gender inequality can, are a risk factor for domestic violence, but they also create barriers to help seeking. And to be trauma informed, you really have to think about how all these psychosocial factors around the person, those systemic factors, create barriers to getting your help and your support. And what does that mean for your approach, the environment in which you work, who you are and how you provide services, your workplace culture, and even partnership with services. So we'll mention that throughout this webinar as well. I've talked a little bit about trauma-informed care and its aims. So as I just said, one of the critical things in trauma-informed practice is to minimize the barriers that people experience in accessing or engaging with services. And that includes things like, how does a person identity, circumstances, both impact on trauma, but the way they're going to really relate to me and the service I'm in and addressing that. It's also important to think that services inherently can be harmful to people who have experienced trauma. So an example of that is that you might be in private practice and you are supporting someone through their trauma. The fact that you're supporting them already puts you in a position where you have power in the relationship. You're the one making the assessment with them. You're the one providing advice and support. And sometimes power and having someone that has a little bit more power than yourself when you've experienced trauma can feel incredibly threatening and can feel coercive, particularly if you've been harmed by someone else. So thinking about, are there things that are inherent to service delivery that might be experienced as harmful or actually harmful, like restrictive behaviors, like using too many drugs to restrict people being really distressed in hospital settings, for example. Trauma-informed practice is also about supporting recovery from the impacts of trauma, no matter what your role is. So it's thinking about recovery, even if you're someone on the phone, assessing someone to see if they can go on a waiting list for your service and you're an intake worker. Even then, it's thinking about how can I support someone's recovery by getting them to feel safe and understand what the aims of the services are and feeling like there's no sense of hopelessness as I'm waiting to be on that waiting list for the next 2 months, for example. And as I said, critical to trauma-informed practice is worker safety and well-being. It's impossible to be trauma-informed without feeling safe yourself. Next slide, please. We are going to talk about a whole range of principles of practice. I'm not going to go through each principle in this webinar because we're going to focus only on some principles. But one of the things that I want to mention is that for us, as we're going to be speaking to you throughout the day, the hour, is to really think about how service users, their families, their carers, or your clients have a central voice throughout the care they receive. So that means, feeling like they have choices, feeling like they understand their care, that they can provide consent, but also that they're seen and that they're empowered to make decisions throughout the process. For us, that's really, really important and something we're going to talk about throughout this webinar. Next slide, please. So let's talk in practical terms about what it means to create emotional and physical safety in trauma-informed practice. What we're talking about here, first and foremost, is really making sure that you understand the experience of a person's, how a person has experienced trauma throughout their life, and ensuring that the dynamic between you and that person or the dynamic set up by your service doesn't reproduce what's happened in a trauma. So being mindful that if you're making decisions with a person and you're not replaying a sense of powerlessness in the relationship, for example. That if the person was in situation like a bushfire or an accident or a family violence situation where there's a lot of uncertainty, that you're not reproducing lots of uncertainty as they travel through the service system or receiving care from you. Everything is as predictable as possibly can be, for example. And it's making sure that you have spaces that are accessible and culturally inclusive and feel safe. So that means that they walk into a space where it feels like they're a human being, that they're being seen, that maybe there are workers there that look like them, that can speak their language, for example, that they feel welcomed, and that they don't feel uncomfortable as they are sitting with you in this space. Next slide, please. So in terms of safety, there is a hierarchy to thinking about safety in a relationship, and many of you may be familiar with this, but it's really core to trauma-informed practice, and that first and foremost, trauma impacts on your safety both within yourself and within relationships. So it impacts on your ability to trust other people often, trust that the world is a safe place, other people are safe, but it can also impact on your physiological safety. So often, as we know, trauma leads to a sense of being always on the lookout for danger, always tense, always hyper alert. And that means that often you don't feel safe within yourself, within your body. You might not be able to trust that you can help yourself not feel angry all the time or not being able to sleep, for example. So when we think about safety, it's creating a safe relationship where there's warmth and respect and kindness and where a person feels seen, but it's also about feeling safe within your body and feeling calm and being with someone that doesn't parallel your own tension and your own panic or your own fears. So someone that doesn't react, that's calm, that uses themselves and co-regulates with you. That means feel calm with you rather than just giving you techniques to feel calm, for example. It's then about providing things that might help, information that might help you feel safe. Like these are what you can expect from what we're going to do together. This is what how we're going to problem solve together. I'm your partner, and we're going to do things together, and we're going to work together. Uh, this is where you might give information about consent and making sure people feel like they can change their mind, that they can consent to sharing information. But that really comes last into creating safety. And often what I see is people don't really think about that hierarchy, and safety is not there for the person attending the service. Next slide, please. The other thing to think about in both creating safety, but also making sure that people have a sense of power and control when they're interacting with you, is that they have a sense of choice. Now, choice is not just about making decisions together and having enough information to make those decisions. It's really feeling like things are not being done to you, but you're doing things with the person the whole way through, so that you have enough information and you feel seen enough that you feel like you're a team working together. Uh, and that means that you have visibility in the relationship, that you have a voice in that relationship. And it may mean things like checking in and making sure that what you're doing with that person works for them and fits for them. So there is very good evidence, for example, in counseling, that asking every session or every other session, are we on the same page here? Is there anything that's getting in the way of you feeling comfortable with me? That asking those questions, making them overt, is so incredibly important for the person to feel like they can say, oh, I've changed my mind. No, I don't think you get my point of view. It's also, as I said before, about predictability and knowing what to expect and what's next. And it's not just about setting expectation by providing information about what's going to happen next. It's also doing what you say you will do, of not over promising, uh, really making sure that the person is able to also sit with information and digest it, not rushing through explanation, those sorts of things. And also making sure you've got a practical fit with the person you're working with. Are you giving information choices that fit with their context and their needs? For example, thinking about the effects of trauma and how that might impact on that person. Are you asking them to do things when you haven't addressed avoidance, and they're doing everything they can to not feel, think, or avoid reminders of the trauma, and you're asking them to confront something they're not ready to confront? Or are you aware their literacy has been impacted by trauma, but you haven't thought about to what degree it's been impacted and what's difficult for them? Is it writing? Is it reading? Is it certain language that's hard, for example? Next slide. The other thing that's important in trauma-informed practice is really thinking about how you're going to help the person share their experiences of trauma in a way that feels safe and comfortable for them. And the key thing to that is really being clear about the purpose of being trauma, to sharing the trauma and what's happened for that person. So that means making sure you don't have different expectation about what it means to share the trauma. And that means thinking about, why am I asking those questions? Is it to understand symptoms? Is it to think about, what might impact the experience of the therapy or the support that I'm providing? Like, I need to know that certain smells or certain interactions are really feeling threatening for them, for example? Or is it to help them feel seen, feel like you know what they've been through, and it helps you acknowledge their strength, and that you can and create hope that we can talk about these things, and it's not gonna destroy you, it's not gonna be very difficult, and it's not doesn't have to be a secret for you. Uh, so being very clear around, if I'm asking someone to share their story, what does that mean? Is really, really important to think about, and to do that with a person when you can, if they're not feeling too overwhelmed. Actually saying, um, for example, I'd like to hear about what happened to you so I can understand how, the lack of sleep and the fear you've told me about really impacts on you, for example. Um, how does that sound to you? Were there other times you shared your trauma? What was that like for you? Yeah. Can you go to the next slide, please? So there are some key issues to consider when you're talking about trauma with someone. One might be, what makes it safe for a person to disclose. So, are you in a place where you can slow things down and really give time to people to share their story? Do you have the skills? Do you know how to contain it and to um, shift the person away from the story if they don't feel safe telling you that story? Um, and very, very importantly, how do you make sure that someone doesn't have to tell their story over and over again? And that means being very clear about how you share information, how you use information, um, and the person being very clear how you share and keep a record of that information as well. Some of the tools that I mentioned have tools for both um, workers, but also for service users around talking about trauma. So there's some great handouts, for example, that you can give someone before you talk about trauma to give them permission to talk about it, but also to set up expectations. So you can have a look at that on the website if you're interested. I think I've gone well almost over time, so I'm going to hand over now to our next speaker, which is Christabel, and she's going to be talking to you about um, how across disciplines, I might skip that slide, thanks. Across disciplines, how you share trauma-informed language and how that strengthens your practice and then reflective practice. Over to you, Christabel.
Thanks, Anne-Laure. Yes, so I was involved in one of the working groups that was consulted with for the development of the suite of trauma-informed practice tools that were referenced in this presentation. And one of the biggest things that struck me about that, or what I appreciated about that project, was how it consolidated a lot of the trauma-informed practice knowledge and research that's in the space. I think as ground workers, it can be really difficult to understand what trauma-informed practice is. There's a lot out there. And so I appreciated the consolidation of this into language that is accessible. And so when I'm talking about shared language, what I'm talking about is a shared definition and of an understanding of what trauma-informed principles are, as well as what that looks like in practice. And that when this language is created, when this knowledge is created, it is done in consultation with everybody who is going to be using that. And yes, that is service workers, and that is also importantly, and service leaders and peer workers, but importantly, it's also consumers. And so that is what I really appreciate about this kind of shared language on trauma-informed practice and why I wanted to speak on it. And I just wanted to quickly speak on how it's helpful for three groups of people. I've listed them here. I'll begin with the peer workers because that's where my heart lays. Um, so, you know, for lived experience workers, our lived and living expertise, it is hard earned, and it allows us to have a really intimate understanding of what are the conditions needed for healing to happen. And, and within this context, within services, for a lot of us, we don't really need to imagine with a consumer walking through the door. We have been that consumer, we are that consumer, we will be that consumer. And so we have this incredible expertise. I'm not sure how many peer workers are here today, but yeah, we have this incredible expertise. But it's really important for us to understand that we are working in a system that has this really dark historical legacy of silencing consumer voices, of not believing our stories. And there is an absolute hangover of that still that we are transforming in the system currently. Um, and I speak to this because it is really important for us, for lived experience workers, to have language that we can translate our expertise and speak and articulate it in the shared language and can be understood across disciplines. So, um, yeah, I wanted to just really speak to that. Um, I also wanted to acknowledge, the Brimbank Local has been using these tools for a while, and so I want to honor that. I've had peers also reflect back that being able to understand their skills and knowledge and practice within a context that is cross disciplines has been really affirming as well. So, just wanted to mention that as well. So, for shared language for clinicians, how it can be helpful is, everyone who's here today, I trust that we all understand that things need to change, really want to be committing to strengthening our practice to be more trauma informed, more person centered, kinder, and a really good. And I think it's a really valid question, and a question I hear from the clinicians I work with, the clinicians I meet in the sector, is I want to do this. I want to be committed. How do I do this? And that's really valid. We need to have answers as well to the criticisms we are facing. And language is a really good place to start. Language, a lot of the language, a lot of the knowledge approaches to care we have historically, traditionally, are not neutral and are not and perpetuate harm. And it's really important for us to be in, engaging in knowledge that has been created with more people, all the people that are impacted by it involved. So I say that, you know, opportunities, initiatives like this, in which we are defining what trauma informed practice is and we're explaining what it can look like, and that has been agreed upon by and led by consumers, is a really meaningful way for you to commit to trauma informed practice. I hope I got my point across there, but I'll carry on. And then, of course, for consumers, having trauma-informed practice and what that means really clearly established and consistent across services, across workers, across disciplines, enables consumers to have really clear understanding of what it is. It's not abstract, it doesn't vary, principle wise, and thus have clear expectations for for the services, what they can expect from services, and then also really be able to make sense of their experiences within a service and articulate how they're understanding their experiences to workers in a way that will be understood. Essentially, it's really helpful for self-advocacy for consumers, is what I'm saying. Next slide, please, Akin. So I'm also going to touch briefly on reflective practice. It's just essential if we want to be, if we really want to be committed to trauma-informed practice, it is a necessary commitment to reflective practice. We are all human beings with worldviews, and that impacts how we show up in spaces and how we understand each other. And it is a responsibility for us to consider that and to consider how that's showing up in our practice. I feel like we all know that, and really it's more a question of how do we do reflective practice when we are so time poor, have so many competing demands and priorities. But I just wanted to reiterate that and maybe really speak to if any leaders or any people who are able to influence culture and organizational structures, that if your service, if your organization says that they are committed to trauma informed practice, then they need to be committing to supporting their workers to have meaningful reflective practice spaces. Um, Next slide, please, Akin. But um, we all do have a part to play in reflective practice, and I guess I'll speak briefly on what it can look like for, as the ground workers. I know that it can be really difficult, especially if, yeah, we don't have those designated spaces. And I just want to encourage people to be creative and creative about what where moments of reflection can happen in their day. And I say this both because it's important for our practice, but also because it's important for our well-being. We need to be reflecting to be able to digest um, the activations, the tensions, the myriad of things that are happening in our day to day as we do our really important work. Um, and so I'm not sure how we're going for time, but I might just say, like, if we're being curious or creative about reflective moments in our work, um, it could look like time blocking some of that time in your supervision, and for reflective practice, for you know attention you might be having in your work, and really just letting yourself chew on that with your supervisor for 15 minutes, not problem solving, really being like, what is coming up here. um it could also look like, I'm sure many of us have those really special colleagues that we will check in with throughout our days, just to maybe after an intense session we might go to them and just be like, that was really intense. And, you know, maybe thinking about how in those moments could we bring an intention of reflection to those, um, just some ideas I have. But that's me, and I'll bring it now to Raul to speak on risk management.
Thanks so much. Really important points throughout. Um, so look, I'm due to speak about trauma-informed risk management, and this is always one of those tricky spaces where we do run into a real tension between two sometimes competing concepts. So duty of care in this instance really refers to our duty as providers to maximize harm and sorry, minimize harm and maximize safety. Um, and and that sometimes has a well, often really stands in tension to the concept of dignity of risk, which is really about empowerment and enabling consumers to, and indeed their carers, to be able to choose the life that they want to live, um, even if that sometimes involves a bit of risks. And I think these two perspectives are really important to keep in mind. Oh, we've lost the slides. Can we? Thank you. Gotta watch the wandering mice. To have to find that balance, and I think this connects in importantly, really, to some of Christabel's points around reflective practice, because one of the things um, that is important to keep in mind is that often risk tolerance is much more of an individual personality trait, not necessarily an organizational one. And if you're in a leadership position, often that personality element and your personal risk tolerance can cascade out to the broader team. So that self-awareness of where you tend to sit in that kind of what your natural inclination tends to be in terms of how you think about risk and how you think about safety, and is like a really important one to enable the implementation of that right balance between um, the dignity of risk and the duty of care. We skip ahead for a moment to the next slide. Thank you. Some of the things that really do enable that, though, and that level of kind of we sometimes also refer to as therapeutic risk taking, is a collaborative approach. So collaborating not just with the consumer, but also across your team in making sure that you make plans that take into account those different perspectives on risk and what maintains safety. Having some clarity as well between individuals in the team and what their role is in holding risks. Sometimes there can be assumptions. Often in clinical teams, the psychiatrist is kind of the holder of the risk, but that can be problematic in its own way, and sometimes those expectations need to be made as explicit as possible, and sometimes there's that balance between who's holding it and who's able to kind of create the environment or has the time and the relationship to create the environment that helps for that adequate balancing of those two principles. Um, Really critical though to make sure all of that planning is really strongly grounded in the person's actual past experiences, how those risks have been managed in the past, their needs, their strengths, their goals, and that needs a lot of that a return to that foundational principle of moving from, what's wrong with this person through what actually happened to them, and how that experience of trauma may shape, I guess the experience of the consumer and how they're interacting, I guess, in that clinical environment, clinical or service delivery environment. Um, and I'm often reminded actually of the importance also sometimes that within a team context, often it's only a couple of individuals that hold the knowledge about what experiences a consumer have gone through. Um, and that can be a bit of a double bind insofar as you don't want to, as we've discussed, there is an importance in having awareness of what your role is in terms of how much you dig in and hold in terms of the details around what happened. But sometimes it is critically important that some of that insight be shared so that the right empathy and the right understanding can be held across a team. So sometimes I found it really useful and grounding to remind people about some of those experiences that an individual might have had, particularly where it might link in with restrictive practices and the parallels that there might be. But sometimes, and I was reminded of this in particular on call a couple of weeks ago, where a specific team had had their own traumas in a reasonably well publicized incident around being filmed, for example. And so a consumer kind of engaging in filming behavior had been really triggering and problematic for the staff as well. So you got to kind of be aware of both sides of the equation and try and kind of create that mutual empathy and understanding to be able to adequately kind of balance those risks. And certainly the time to reflect and look after your own well-being, which we're going to get to, is another critical aspect. One of the manifestations um, of trauma and distress is often hypervigilance as well. And so you might find if you're a service provider, your consumers are actually often much more acutely attuned to your mental state and well-being than you are of theirs at times, just because as a survival technique, sometimes they've had to have that real acuity, and sometimes it can be it can lead to misinterpretations as well. But that acute awareness is something that you have to be quite aware of. And we've got a few toolkits, a few aspects of the toolkit that kind of speak to this. So I won't run through those in detail, but it's worth checking out. We jump to the next stuff then. So to help get to that kind of information that can help have a plan together, it's really important to move past assumptions that we might hold about things, and again, without kind of going into the detail of each and every concept, which you can explore in the toolkit, if I just pick, for example, in this flower of the impact and function, that can be a really interesting thing to dig into directly with your consumer. So how does a particular risk that you've identified together, how does it play out in their everyday life? And not just the risk itself, but how addressing that risk in different ways might impact their functioning day to day, for example. And sometimes they can be a bit of a double bind or a tension. So, for example, you might be looking at bringing someone into hospital, but their main distress tolerance kind of thing, or their reason for living is a pet, or is someone that you're then going to have to you're disconnecting them from in some way. And so some of these kinds of more subtle concerns might be things that a consumer doesn't share necessarily without being explicitly asked, but can be really foundational to that balance of risk and safety. And there can be sometimes some ambivalence around someone wanting a type of help and support, but knowing that in other ways it sort of undermines some of the things that can be helpful and grounding for them. So exploring that and being able to be in a space where that is a collaborative, shared um, sort of experience and knowledge base that you can work from as a foundation can be really helpful. Next up. So returning to that theme, yes. Thanks, Catherine. It's always a gem of the one that does the keeping the pets alive and well outside of during the inpatient context. So returning to that theme, I mean, one of the recurrent themes when we do co-design work really is that often consumers tell us that they experience stuff as being quite traumatized. Um, and so that importance of the self-reflection, the well-being as individuals, as colleagues, as leaders of teams becomes really important. And I think it is that there's multiple kind of risks when this is um, not held well. Sometimes it can result in more punitive actions or behaviors. Sometimes it can manifest as um, uh, as that um, difficulty in being able to hold people's stories. Often people who've had a traumatic experience relate stories to me, or have hold fears that because their memories are so unmanageable for them, that if they kind of tell or share that with someone else, it will break them as well. And so I think if we're also not doing well and we burst into tears, or we really struggle, there can be that reinforcement of some of those beliefs. And look, we're all human. Sometimes that does happen. And so then going, okay, this is not the end of the world. Being able to model kind of, again, getting back into a more regulated state, or conferring with your colleague and getting supervision, and being able to re-explore that with that individual, saying that can also be be a healing and an opportunity, and an opportunity to also model sort of self-care and strategizing. Um, so I guess, being human, looking after yourself, and also not worrying if we don't land this perfectly each time, are all interconnected and important. Um, it is important, though, that it is not just an individual approach. So some of those kind of key drivers around team culture and leadership, having that clarity on roles and responsibilities, and feeling empowered and skilled to handle situations are all kind of important in enabling that well-being to be able to practice in a trauma-informed way. Next up. Thank you. And boundaries are the other key, really setting healthy boundaries both with clients and in teams themselves. And I guess the key tips there I'd say is that it's really important to be on a similar page um, with your team around some of these things. As flagged kind of earlier, often some of our approaches to to risk can be kind of more individual personality traits, and reflective, obviously, of our own kind of training background or clinical experience and lived experience. So having those reflective spaces to be on a similar page as a team, and then being able to convey and uh, engage in a kind of shared understanding with the clients, are both really important. Boundaries work best when all parties are in a space where they are sort of able to co-regulate, have a foundational kind of alliance or relationship with each other, warmth and respect, etc. So that whole sort of relate, regulate, and respond kind of context really means that your boundaries are likely to be set in a space where they're both respected and not seen as a punitive or a kind of othering or a disempowering kind of approach. So always kind of trying your best to establish those boundaries early in an encounter or in a therapeutic work with a client is really important. All right. I think that's about it for the slides. We'll shift over to Q&A now. Thank you so much.
Thank you, Rahul, for your presentation. Thank you, Christabel. So we had a few questions. Akin, were there some that came out as monitoring the discussion that we should address? Maybe while Akin gets back to us, I don't know if you, one that I saw is trauma-informed practice.
Sorry, Anne-Laure, I just realized my mic wasn't working, but it should be now. Yeah, I've just posted the questions directly to the chat for yourself, Rahul, and Christabel as well. So we had some great questions coming through.
Yeah. So one of the questions that I'm picking up on was, whether trauma-informed practice has an impact on outcomes for clients, including PTSD, for example. And one thing that I would say is that we increasingly have, it's early days in a research. It's hard to do really good research within a service and looking at the actual reality of what happens in a service. But there are some really good indication now that not only does it impact on mental health outcome and well-being for clients, so we are seeing changes, not in particular diagnosis, that's not the research we tend to see, but we do see people reporting, much better outcomes in terms of their functioning, their mood, their engagement with people in their day-to-day life. But we also see really good outcomes for workers, so around the well-being and mental health of workers using a a trauma-informed approach. So that was one of answer that I could see there that we could answer. I don't know, Rahul, if there was one question there that you would like to answer.
Look, I think there was some commentary around the role of power as well in collaborative or supported decision making, and yes, I absolutely agree that the focus is on helping people express and enact their own views rather than kind of imposing those on others. And sometimes just acknowledging the power situation and dynamic within that conversation itself can be really empowering. Shane also had a question there around planned admissions for clients with BPT and whether they're beneficial. Look, I've had I've come in a bit of a circle on this question. So I suppose my reflection is that unfortunately an aspect about what is beneficial and not kind of just comes from the reality of often individual units or the models of care that we have. So I think sometimes we can conflate like what's actually available and whether it's helpful versus what might have worked if we had the right kind of resourcing or approach. So I think in general, I'd say it's best that we move to an individual approach rather than a diagnosis-based approach for these things. Often it might be an individual person's style of coping or the specifics about their trauma experiences that will determine whether or not something is or isn't beneficial as an approach.
And Christabel, did you have anything you wanted to say either about shared decision making or any of the questions asked so far? I think you're on mute.
Yes, I was just thinking, I appreciate Ashley highlighting the difference between collaborative decision making and supported decision making and how there is power. I think we are, I think I'm just echoing what Raul was saying, that we are moving towards, supporting people to make their decisions as much as possible. But I think maybe I'm just thinking that there is both are still needed at this point in time. And I guess I'm just really thinking about what you was talking about earlier, and Laura, about supporting decision making or providing people to make informed decisions is so much more than about providing options. And we do really need to, I don't know if we'll ever get to in the system completely removing the power of a worker in that equation, but we can definitely move closer and closer to reducing that imbalance through really meaningfully thinking about what is supported decision making, what is collaborative decision making, and it isn't just giving A or B. It's not, yeah, it's so much more than that. That's all I'll really say on that. Just echoing both of you.
Yeah. And also we had a question about the model we use, which you are right, Karen, is based on Perry's neurosequential model to a certain extent. We haven't really changed the model as such. We just made the language a bit more accessible in collaboration with the people we worked with, because a lot of people we talked to during those 18 months found that they wanted to get rid of the jargon as much as possible. So that's the only reason that was changed. Not in terms of what it is, it's really the same. And more being a bit more precise, you'll see in the tools around what it does in terms of behavior. So that's the only reason. Yeah, if that makes sense. We're almost at the end. There were some great questions. We have a few, I think that's the last questions that I've seen. There is a question about embedding trauma-informed practice in disaster situation, especially at the early stage. I think some of the models we have for disaster work are trauma-informed in the sense that they say don't make any assumptions about rushing in and attending to a particular model of psychological intervention. That in disaster, people often they're more, really attending to what the person wants at that point in time in disaster, and attending, and also having that view that you're not just attending to an individual, but a whole community and an individual within a community, which again is key to trauma-informed practice. That sense that we're not looking at trauma individually. That's not trauma-informed. The person lives within a family, within a community that's affected, and that impacts on their experience. That's particularly important in disaster. So, when you see those disasters where you send 20 psychologists in rushing in to rescue people and work on their trauma, that actually is not trauma informed. And the models that we have now really talk against that. So hopefully that answers your question, Sue, around disaster and trauma. Yeah. And I think that's all the time we've got today in terms of this webinar. Thank you so much for attending. We're very grateful for all your questions and your thoughtfulness in thinking about this webinar. This webinar will be recorded and available on the Collaborative Center's website. And as I said, the Collaborative Center is also working to put the recording of the webinar we did for managers and leaders as well on that website, so you'll be able to access both. We would encourage you to look at the tools that really help you in a very flexible way examine your practice. So thank you very much for joining us. We wish you all the very best.